Hello, everyone, and welcome back to our Institute for Global Health Sciences COVID-19 series. Today, we continue having a comparative analysis of public policies and impact of those in different countries. Today, we have two great speakers, one from East Africa and one from West Africa. I will introduce first our East African speaker, my dear friend, Dr. Alex Coutinho. I met Alex Coutinho in the 8th conference in Mexico City. I believe it was 2008, if I'm not mistaken. And that's the first time I saw him, but I knew him by reputation as a champion of HIV/AIDS in Africa. He was already a very famous doctor when I first met him. He has received the Noguchi Award. He was at the time director of the Institute, of the Infectious Diseases Institute in Kampala, Uganda, at the Makerere University. He was also chair of the board of IAVI, the International AIDS Vaccine Institute, someone with enormous reputation in Africa and worldwide. So we are very fortunate to have him today, giving us a glance of how are things in East Africa, particularly Uganda, with COVID-19. Alex, you have the floor.
Thank you. Thank you, Jaime, and thank you for that very generous introduction. I'm speaking from Kampala, Uganda. It's 10 o'clock at night, so if my brain is slightly slow, you will excuse me. I have been mainly working in HIV and AIDS, but for the last months, of course, all of us have been experiencing the COVID epidemic in one form or another, and also trying to learn as much as we can about it. And so I want to spend about 10-15 minutes talking about how the COVID-19 pandemic has affected East Africa, both as a disease, but also the collateral damage that has come out of all the other impacts that the pandemic has had on East Africa. And for East Africa, I'm really going to be talking about Uganda, Kenya, Tanzania, as well as South Sudan, Rwanda, and Burundi. And right from the word go, I need to say that, in fact, for Burundi and for Tanzania, we really don't know exactly what is going on. And that is because we don't have enough data, and the collaborations between the country and the WHO and other entities that have been collecting data were cut for various reasons that I'll come to, because of course this epidemic in East Africa, just as it has in the United States, has intersected with politics, and there has been politicization even of the data and of what actually is going on. So I really have two slides to show, and then I will give a general talk about what has worked and what is challenging. In particular, I will speak more towards Uganda and Kenya that I know much more about. And then hopefully some of the other issues will come up in question and answer. So maybe if my first slide could be projected. So this slide is taken out of a publication from last week in Nature that was published by Africa CDC. And one of the lead authors is John Ngengasong, who is the director of Africa CDC. And it shows, the cumulative numbers up to 22nd of May. I show this slide, even though it's about 4 weeks old, because it shows two things. One is it's one of the few slides that actually easily shows how COVID-19 has been distributed across Africa in terms of West, Southern, Northern, Eastern, and Central Africa. And as you can see, the red, which is East Africa, is perhaps the smallest portion as of 22nd of May. Now, the cumulative number of cases for Africa 4 weeks ago was 120,000. And that took 2 months. It took about 13 weeks from the 22nd of March to the 22nd of May to get to 120,000. As I speak today, we are at 250,000. So we've hit 250,000. And that increase has occurred from the 22nd of May up to the 16th of June. So probably about just over 3 weeks. So we are definitely, as a continent, we are definitely in an acceleration phase. Where that acceleration will take us, I can't predict, because in real terms, these numbers don't compare in any way, for instance, with the numbers that we are seeing in the United States or even in Europe. But it could just be that Africa is very much in the early stages of the epidemic. So if I get my second slide, which brings us up to date to what is happening in East Africa as of today, you can see that the total number of cases compared to what's going on, say, in the United States is not very big. Over a period of 3 months, Uganda has registered 724 cases. A country with the largest number of cases is Kenya, with 3,860. The data for Tanzania is completely unreliable because they have refused to share any data for 5 weeks. And in fact, the president has declared Tanzania COVID-free and is encouraging tourists to come back to Tanzania. I'll come to that. South Sudan is also seeing, for the region, a pretty bad epidemic. And in South Sudan, a number of the elite, including the vice president, have had COVID-19. He has since recovered, but there are reports that a number of senior military generals have died of COVID. Rwanda has had 612, and Burundi, again, the data is very unreliable. We know that the president Nkurunziza died allegedly of a heart attack, but there are those who say it could be COVID related, but we know there's far more COVID in Burundi than 104. And coming out of an election where there was no social distancing whatsoever, and where WHO was kicked out of Burundi, that data is unreliable. I just show it to give a picture that, in fact, even in East Africa, COVID is not homogeneous. Each country has its unique circumstances, and each country is got factors that are driving the epidemic more than other countries. And I will spend more time comparing, say, Uganda and Kenya, which I know far more about. As Tanzania, I can't speak to because none of the data that I looked at is very reliable. So my brief was really to say, what lessons can we learn? And if you go all the way back to March 18th, when Uganda locked down the country, at that time, I don't think anyone believed that a country or countries could lock down the way in which Rwanda, Uganda, Kenya, for instance, locked down the citizen and asked them to stay in their homes for 6 weeks without an uprising in the citizenry. And so one of the key lessons for me is that early lockdowns were possible, and early lockdowns actually worked to limit the spread of the disease from the imported cases, because for East Africa, all of the COVID-19 cases were imported initially through airports, through air travel, a few cases from China, the majority from Europe, and a few cases out of the United States. So early lockdown, including shutting down air travel completely, in the case of Uganda, limited our early cases to about 55 and then some of those got some secondary cases. I think the big lesson learned since then is that even though our borders as East Africa were locked down completely, we cannot travel, say, from Uganda to Kenya or Tanzania or vice versa. The borders were kept open to allow cargo to travel. So we have, on a daily basis, about 3,000 trucks that come into Uganda from Kenya, and about another 500 trucks that come in from Tanzania and from Sudan. And right now, as I speak, say out of those 700 cases of COVID in Uganda, almost 500 are from truck drivers. Partly because that's the population that's being tested, but partly it's a reflection that they are coming from countries that have a bigger COVID epidemic than Uganda. You know, Kenya has bigger numbers, as you saw, and even though Tanzania says it has few numbers, we are getting reports that Tanzania is quite a big epidemic. So one of the lessons was that an important hotspot that Uganda needed to focus on, and now Kenya is also focusing on, and I believe Tanzania to some extent, but Rwanda as well, is monitoring and testing every single truck driver that is entering the country. Now, of course, there have been challenges. There have been challenges in finding test kits to be able to test them. There have been challenges in getting results in time. In the case of Uganda, we would allow the truck drivers to enter the country, and if they tested positive, then they would be traced somewhere in the country. But then they quickly realized that many of the truck drivers were giving wrong information. They were switching off their phones and were difficult to trace. And so now all truck drivers have to wait at the border to get their results, which meant that sometimes at the borders there was a congestion of 3,000 to 5,000 trucks, which in and of itself became a very big risk factor for COVID. So right now in East Africa, a population group that is very much at risk of COVID-19 and that has high test rates are truck drivers. Interestingly, this was the same group of individuals who had high testing rates for HIV and who are involved in the spread of HIV into rural areas and into different parts of Uganda and East Africa. No fault of theirs, but this virus, just like HIV, will find a way to travel. And right now in East Africa, our road networks and trucks in particular are the way in which the virus is traveling. Now in Kenya, there have been some additional hotspots. And as a consequence, Kenya quarantined these hotspots to prevent people moving into the hotspots and moving out of the hotspots. The coastal city of Mombasa became a hotspot, and in particular, what's called the Old Town, the original part of Mombasa that was built by the Portuguese when the Portuguese had colonized that part of Kenya, is called the Old Town. And there are many reasons why there was a concentration of the COVID there. Part of the reason that was given was that during Ramadan, which is a period of fasting for Muslims, there is a lot of social activity involved, and that this could have magnified the epidemic. The second hotspot was a place called Eastleigh in Nairobi. So Nairobi itself as a city was quarantined from the rest of the country. But Eastleigh, which is within Nairobi and has a high Somali business population, was also a hotspot. And by doing testing and contact tracing, the government of Kenya was able to identify these two hotspots and quarantined the entire population for a period of 30 days. They've since lifted the quarantine, but these were some of the measures that were used to limit the spread. In the case of Uganda, of course, we've had several Ebola epidemics, so the population was well aware of the concept of an infectious disease. They were well aware of the concept of social distancing, because we had used social distancing to respond to the Ebola epidemic. And they were well aware of the concept of contact tracing and quarantine. So it was much easier for the Ministry of Health and government to implement social distancing, to implement contact tracing and quarantine as quite effective interventions. In Uganda, because the numbers are still small, anyone who tests positive is moved to a government hospital to be observed, whether they are symptomatic or asymptomatic. Of course, if the numbers got to be too big, that policy wouldn't work. This was a policy that was used by China very effectively to separate COVID-19 positive individuals from families to limit further spread of COVID within families and communities. This is not a strategy that the United States used early on in the epidemic, and I don't think it would have been possible because of the laws and civil liberty structures within the United States. But in China, it was possible. And in Uganda, it's also been possible because the numbers are small. In fact, even those who are contacts but have not yet tested positive are being isolated in government-run quarantine centers, which from an infectious disease point of view is good. But some of those quarantine centers have been abused, and quarantine has been used as a punishment for people who break curfews. And unfortunately, it has undermined the trust of the public when it comes to understanding why they are being quarantined, because they may not see it as an intervention to stop disease spread so much as they see it as a form of punishment. But so far, our numbers are pretty small because we still have a form of lockdown in place. Now, if you look at East Africa, the lockdowns have been quite different. So in Tanzania, there was basically no lockdown, other than the schools were closed, but worship was kept open and encouraged. Markets were kept open, transport was kept open, the borders were closed, mainly because other people closed their borders. So Tanzania had a very, very light lockdown. Kenya had a more stringent lockdown, but it maintained its essential services, it maintained public transport, and people could continue going to work. Uganda had a tougher lockdown than Kenya. So you can see the gradation from Tanzania to Kenya and then to Uganda. In Uganda, very few employees, essential services essentially were allowed to go to work, and public transport was shut down. And because public transport was shut down, the population could not move around. And we have been in a curfew for the last 3 months, from 7 in the evening to 6:30 in the morning. So at night, there is no movement whatsoever. Schools were closed down. All churches and mosques were shut down up to now. All bars, all gyms. And it's only recently that shops and shopping malls have been allowed to open. However, lockdown, in retrospect, lockdown was the easy part, because lockdown was driven by biomedical science. Essentially, we knew we were dealing with a respiratory infection. We could already see the impact of that virus in China and in Europe at the time that we locked down. And we knew that it was killing people. So there was a fear factor within the population, and the population itself was willing to be locked down because of that fear factor. And governments were using the knowledge that we had about the epidemic then to effect what is essentially good public health practice in tackling a respiratory infectious disease. Now, the challenge is lifting lockdown. And all of our countries are going through these challenges because we stop using pure biomedical science and we start moving into the areas of sociology. We start moving into political science. and we start moving into economic science. And you have to use all of these to decide whether you want to lift your lockdown. And paradoxically, many countries in Africa are lifting their lockdowns as the number of infections are on the increase. Logic would tell you that you lift your lockdown when your numbers are decreasing. But in fact, the collateral damage that is coming out of the lockdown is in some cases estimated, I don't have the data, but is estimated to be worse than COVID at this point in time. So for instance, we know in the 2014 Ebola epidemic in West Africa, now that we've had time to look at the data, that if you look at the total number of deaths due to Ebola, which were about 11,000, those number of deaths were actually much less than the deaths that happened because other health conditions were neglected or people were afraid to use the health systems. So deaths due to malaria, maternal and child health conditions, children who are not receiving vaccines, surgical cases that could not make it to the hospital or were afraid of the hospital. And we are seeing exactly the same thing with COVID-19. There are many reports of hospitals that are empty. We were worried at some stage that hospitals will be overwhelmed. Well, many hospitals are empty because people are afraid to go to hospitals because hospitals are associated with COVID-19. And even though we don't have the data, we can predict that because of the lockdown, because of the fear of COVID, that the numbers of death due to malaria and TB and possibly HIV and maternal and child health will probably spike. And because the health system is not working as well as it should, in particular, individuals with chronic conditions, non-communicable diseases, HIV, mental health are probably going to suffer. But the other collateral damage is, of course, on the economy. Our countries in East Africa generally, our economy can be in sort of 3 or 4 main categories. So the rural population has not been affected very much. Most of them are engaging in agriculture and have been encouraged to continue engaging in agriculture. The challenge has sometimes been that the market for their goods is no longer as good as it used to be because of the shutdown of schools and the shutdown of transport. But the rural economy, by and large, at least in Uganda, is not as affected. And then you have the informal sector. These are individuals, and they are in their millions, who survive due to daily casual work. They ride motorcycles, they wash cars, they lift goods, they work as daily paid construction workers. And of course, for the last 2 to 3 months, there has been no such work available to them. So they have had a severe economic impact. And then there's the formal sector, which includes also government employees, private sector. And what we've seen so far is a big hit on the tourism industry, which has gone from boom to zero because there are no tourists whatsoever. And of course, Uganda does not have a big domestic tourism. Most of the tourism was international, and with no flights and no travel, that has collapsed completely. And of course, when tourism collapses, so do the hotels, so do the other industries that are linked to that. So we are already seeing a lot of job losses. And as a result, government is also seeing a decrease in taxes paid. And so all of these decisions, I think, have led countries to decide, even though COVID continues to be a threat, a medical threat, when you put all the threats together, maybe you better just open up and hope that the population will follow the rules that you want to put in place to still limit infections even as you open up. And what are those rules? And are the population actually following them? So clearly, social distancing or physical distancing and hand washing are things that people are used to and by and large, I think are practicing. I think the challenge has been using face masks. There has been no culture of use of face masks in Uganda prior to COVID-19. So for many people, using a mask is strange. Plus, you have to buy a mask at a time when you don't have much cash. And, for many people, the COVID is no longer considered a serious threat because it's not that visible. We've not had a death, for instance, in Uganda. And so as I drive around the city, I can clearly see that whilst there might be physical distancing, people are not using masks and the country is opening up. So we could see a rise in cases, and the Minister of Health has been warning that if people don't follow the guidelines around wearing masks, that there could be a second lockdown. We shall wait and see. It's a story that's still being told. Kenya is also opening up, but is having a steady increase in cases. There's been no talk of a second lockdown. Yesterday, there were 4 cases of employees within the State House, the equivalent of the White House. So there was a bit of a threat to the presidency, and whether the president had been exposed to COVID. Here in Uganda, our own prime minister is in isolation because one of his contacts tested positive, and even though he is negative, out of an abundance of caution, he is in a 14-day self-isolation. So in summary, COVID is real. We are very much in the early stages. The rate of progression of COVID in East Africa has been much slower than had been modeled or predicted, and that's probably because of an early lockdown and a prolonged lockdown. But now that we are opening up, and as we see the number of cases doubling after 3 weeks, it's possible that the number of cases is going to increase exponentially. However, we need to note that the percentage of cases that are getting severe disease and the percentage of cases that are dying is much smaller than what we see in Europe or in America. And that's partly because of our demographics. A large number of our population are young, younger than 50 years. And secondly, we have very little obesity in our populations. And we have a lower prevalence of diabetes or heart disease or hypertension. So all of these are probably protective of severe disease compared to, say, the United States or Europe. So it's possible that we will see an increase in numbers of cases of COVID-19, but perhaps not as much increase in the number of severe cases or deaths. But, this epidemic defies all predictions, and it's a daily lesson in terms of what can happen or not happen. And we continue looking at other countries to try to glean some lessons that can be applied within our context. I will stop right there.
Thank you so much, Dr. Coutinho, for a very, very comprehensive summary of what is happening in East Africa. I know I have many questions for you. Just a reminder for all of our audience to please pose your questions in the Q&A. Hannah Park will be moderating the Q&A component. So please, whenever you want, start writing your questions. Let me now please introduce our second speaker. So we go now to West Africa, someone who is a real expert working in infectious diseases. Dr. Bailor Barrie is a third-year doctoral student at the University of California, San Francisco in global health. He has been working in Ebola for years and now is back home in Freetown working on COVID-19 precisely. So it's a great privilege to have Bailor Barrie present the situation in West Africa. Please, Bailor.
Yeah, I developed some slides that I will share. So yeah, so I've worked in HIV, TB over the years, and also I founded a non-profit that is now partnered with Partners in Health in Sierra Leone, and during Ebola is when we had that partnership, and we were working to help strengthen the healthcare system in Sierra Leone, because we learned that the reason why Ebola actually ravaged the country as it did is because of the weak healthcare system in West Africa, like those countries, Guinea, Sierra Leone, and Liberia. And so my presentation will be like talking about the current situation in Sierra Leone, and then I'll talk about the response achievements to date with some of the plans, like the strategic plans towards trying to end COVID. And then I will review the response of challenges and gaps, just so that people will understand, even though we had Ebola and it's finished, and now we're working on COVID, but still we have challenges that are still affecting the country. And then I will talk from the PIH involvement in the COVID response, because I work for Partners in Health as the strategic advisor to the executive director, and I'm leading the COVID response in the whole country for Partners in Health. And so I sit at the emergency response center with the surveillance team. So, and then I'll talk about a little bit just about the differences between Ebola and COVID, especially in terms of the response. So, today, like as of June 14, we have about 1,169 confirmed COVID cases, and we had 680 recoveries and 51 deaths, like which come up to 4.4% of case fatality rate, and okay. And so this is like just a table showing the different case infections in different districts. And as you can see, Freetown, Western Urban, where Freetown is, have the highest cases, and then Western Rural, which is also adjacent to Freetown, to the capital city, have the highest number of cases. And the reason being is like people that fly out of Sierra Leone and come to Freetown first, and most people live in cities than as in rural areas. And this is a difference between Ebola and COVID, is that we had a lot more cases in the rural district than the capital city. So that's a huge difference. And this just shows like the outbreak by week and like the number of cases per week. And as you can see, week 8 to week 11, we're having a lot more cases. And like week 9 to week 10 is because there was a strike by the contact tracers and lab techs, because they were not paid their salaries, and now it's been paid. And like you can see that the number of cases are rising. Basically, if you look at week 6 to week 8, you can see the cases are rising, and that trend is what we are looking at. That when the early phases of the disease, but like it's really in the rise in Sierra Leone. And this just shows the mean age of the median age of infection, and like how many are males and females. It's just like talking about the different demographics, and like we have for 15.2 cases per 100,000 as prevalence of the disease currently. And this graph shows the mortality and female and males, and like the mortality rate. And this can show the case mortality by age groups in this. And you can see that mostly we have high mortality amongst cases between 45 to 60 years, which are not a small number of cases, as Alex just mentioned, that because the demographic of our countries, mostly we have less people in those age brackets, 45 to 60. And this graph is interesting because it shows that the number of tests done so far, and this is why I'm concerned about the situation in Sierra Leone, because we've only tested 8,549 as of June 14, and which is about 1.12 tests per 1,000 population. So the testing rate is so small, and so if we look
Seems like Bailor, your image froze.
Maybe, Jaime, we can be taking some questions till he gets back.
Right. There are many questions already for you, Alex. So why don't we pause for 1 second with Bailor, have him come back. And Hannah, why don't you start with some of the questions for Alex, please?
Sure. One of the questions from our audience is someone's curious to hear more from Dr. Coutinho on the politicization of the COVID data, which you mentioned in the beginning of your remarks.
Sure, and I guess Tanzania is the best example of that. Tanzania and its president Magufuli has been an outlier in terms of believing the data and being prepared to share that data with the rest of the world. He dismissed claims that this was a dangerous new virus and initially called it, I think, a small flu. He encouraged people to go to church and mosques to pray and pray away the disease, that pray to God that the disease goes away. And recently he said that the prayers had worked and that Tanzania was corona-free. And so they are back open to business and are looking for tourists to come back to Tanzania. Of course, Tanzania economically is very dependent on tourists who come to the beaches, to climb Mount Kilimanjaro and so on. He also ensured that there was a media blackout in terms of talking about any deaths, and yet we hear anecdotally that there are quite a number of deaths in Tanzania. So this is an example of where the president of a country, does it sound familiar, can give a narrative that goes somewhat against the science, and that becomes a politicization of the epidemic. The same happened in Burundi. The late President Nkurunziza held an election, and if you looked at the pictures of the election campaigns and voting, there was no social distancing, there were no masks visible, and he threw out 4 WHO officials. Sadly, he himself has died since of a heart attack, but in a setting where there's quite a fair amount of coronavirus. So those are just 2 examples of where politicians take the narrative and decide for the rest of the population what's going to happen in response to what is very much a medical epidemic.
We actually have a lot of questions for you, Alex. So the next question, 120 cases in 8 weeks, which doubled to 250,000. What have the death rates, what have the fatality rates from COVID been? Have they followed the same sort of trajectory that your original Lancet slide showed?
So it's difficult to give a commentary on the fatalities because we don't really have a denominator that is accurate.
Oh.
So we can count the deaths, and definitely the number of deaths have also increased, steeply. But we don't know the total number of infections that are occurring. So because we are not testing enough, because we don't have enough test kits. There's a big shortage of test kits because the whole world wants test kits. And so a lot of East Africa is doing targeted testing. But the data that we have shows that, in fact, the mortality figures we are seeing are probably much less than what was seen in Europe, but very similar to what you see in Europe if they are age matched. So if you see the mortality in 20 to 40-year-olds is probably very similar. The excess deaths in America and Europe were mainly driven by the elder population who are above the age of 70.
Mm-hmm. Mm-hmm. And have you seen, can you talk about how COVID-19 has affected, you mentioned the delivery of other health services, but have mortality from other causes, has that increased?
We suspect, I don't have data to reference, but we suspect, and we know that there has been a precedent that I mentioned, the Ebola epidemic in West Africa, which disrupted health services generally and led to increased deaths. Now, the tool that you would use would be to compare fatality rates per population for this period of the year vis-a-vis the same period last year, for instance, see if there is what's called excess mortality. For you to be able to pick up excess mortality in a country or segment of its population, you would need to be capturing data very accurately. And that is not happening. So I can't even give you comparative mortality rates for May 2020 compared to May 2019 to show that there's an excess number of deaths and it could be due to COVID-19, which is one of the ways that several countries are predicting that there's in fact more deaths than are being registered due to COVID-19. But we do know that malaria has not gone away. HIV is not gone away. Malaria is more likely to kill you acutely, but if health services are disrupted and people with HIV don't get their medication, they're not going to die, but they may develop drug resistance and then have harmful effects later. Similarly, if people with TB don't get their TB medications, or people with diabetes or hypertension, you may not see immediate mortality. I think the immediate mortality is mainly around maternal and child health conditions, is mainly around malaria, and is mainly around other causes of, say, acute diarrheal disease and so on.
Can I follow on that question from Hannah? We have seen, Alex, that in many countries, certainly in Latin America and in the US, vaccination rates have suffered as a consequence of COVID. Is that something you're noticing in East Africa as well, that primary healthcare, vaccination services, family planning are coming down?
Absolutely, absolutely. And government is trying to find ways to reinvigorate them now, but there's been like a 2 to 3 month gap, partly because of lockdown, so no public transport, no transportation, partly because people are afraid of health facilities, partly because healthcare workers themselves might have been diverted in preparing for COVID-19. There's a number of reasons that's led to that. But yes, I think the decline was estimated at up to 50%. I don't know if it will have a long-term impact if, in fact, now that the lockdown is being lifted, there's catch-up vaccination. You know, if people are able to say, look, we missed our dose, but, you know, let's have a catch-up vaccination. But you still have to get the fear out of people of coming to health facilities. And maybe you need to design outreach vaccination sites so that people don't actually have to come to hospitals, and you take the vaccinations to where they live.
Welcome back, Bailor. Good to see you're back. Your internet was disconnected.
Yeah, my
please
internet,
continue.
Okay, let me just share. My screen.
We can see your slides now.
Yeah, so as I was saying, like, this is like a map that shows like the country and the cases per district, and it just tells you that Freetown, the western area, urban and rural have the highest number of cases here than the other districts. And so then, but what this is just the updates and shows like the current situation. But like what do we consider, or what the government considers as an achievement to date is as Alex said, actually what we saw is early lockdown of our airports and international borders that was actually infected on March 20th. I came on March 13th, so I just came just right in time. But like, and also the national response structures that were established during Ebola that, and I think that's what was positive, is that they built the structures and have these structures in place for any emergency situation. So they were like activated and put in place. I'll show a slide that shows how the structure is. And also they initiated decentralization. It's not only when cases got to the district. As soon as we had the first case on March 30th in Freetown, they activated all the district emergency operation centers where they put the district medical officer and the head of security to take charge and like put all systems in place. And then we increased bed capacity from, we started with 30 beds, but now we are at 3,345 beds in the country, which is great because all districts have bed capacities. And like also in the city, they have about five places, about like 2,000 bed capacity in the city. And like also they created a situation where they call CCCs, community care centers, just like during Ebola. We had CCCs in the communities that are built in the communities, and they bring people from the community there so they don't have to travel a long way. And it's a lesson from Ebola that when we had only 2-3 treatment centers, people have to travel like 10 hours to get to a treatment center. But now they have all CCCs, even in the communities, in the chiefdoms. They have like a CCC that is there to isolate people from the community and put them there, and then when they're tested, if they're positive, they treat all non-complicated cases in the CCCs and complicated cases in the hospital. So it's like different from what Alex described, that all cases in East Africa are treated in the hospital. Here, minimally symptomatic or asymptomatic cases are sent to community care centers, and only severe cases are sent to the hospital, which is also a great success. And also the updated test to primary test. So first, when I came to this country, when we were starting this testing and everything, is like they test only people that have direct contact, primary contact to an individual with COVID. Now they move to like, they test secondary contacts, and like they test you as soon as you are identified as a contact. They will take a sample and test, and then at 14 days, they test you again before you're discharged from quarantine. But the only challenge is like they're only testing people with contacts. They're not like searching for cases in the facility, the patient that comes in the facility with symptoms of respiratory diseases. However, now they're moving towards like training all healthcare workers in the country and putting so that they can identify suspect cases and send them for testing. Because like we have minimum tests, like about 25,000 tests that came to the country. We've only utilized like it's a little more tests. So now we're trying to implement that project where we look at people that symptoms and bring them. And also the country had a lockdown, inter-district lockdown, where people don't travel from one district to the other district unless you have a pass that will take you to the district, or you have a real reason that you're traveling for. You apply through the EOC and then you're given a pass to go to another district. So, and I think that's also what I think is the reason why we're not seeing a lot of cases in the districts. It's only cases in Freetown, and also like cases in the district. All the cases, all the initial cases in the district came from Freetown. So it's like they're strengthening that inter-district lockdown. And I mean, I said there was a 2 weeks that they have strike, and now they've initiated the payment of frontline, and they're mitigating the spread of this coronavirus through the inter-district lockdown. And about 680 cases are discharged and recovered, which is, I will talk about that. But like the strategy now we're looking at, we think right now in Freetown we're on scenario 3, where we have a lot of community spread within the community. So now we're reviewing the national strategy to put us in the state where we are at. Because before, when I came, I helped them develop the first strategic plan, which is like for preparedness. And now we're trying to review it to move into a full-scale infection, basically in Freetown. But as we did the first time, we'll also implement the strategies in other districts. So, and this is the structure that I was talking about. If you see the structure that was built, they have the chairman of the whole COVID response is the president, and under him you have the district coordination, the national coordination, under which you have the district coordinators, and under the district, you have the technical team and the finance and admin lead, where you have these. Also, all those case pillars are basically based on ministries. So you have the Ministry of Health, controlling surveillance, case management, lab, drug, risk communication, food and assistant nutrition, psychosocial, whereas the Ministry of Finance is in charge of finance, the Ministry of Procurement of logistics is in charge of procurement and HR. So it's like it's divided, but like they're working. Basically, the national coordinator and the head of the technical team always meets, they talk and discuss, and then we have a scientific and technical advisory group, which is like in the field. They deal with the M&E and field operation, transport and logistics and all of that. But then they devolve these things to the district, where we have like the district structure. The district structure, you also have the district coordinator, and then you have the technical and implementation section, and then you have the technical pillars, and then you have the mayor of the city is in charge of like the other components like field monitoring, admin and finance, and then you have the district coordinators and then you have the executive support officer, public relation, and then you have the district medical. So in each district, you have 3 leads: the district medical officer, the district coordinator, and the mayor of the city. So they are the lead, and then district medical officer is in charge of all the technical pillars, and then the other pillars are run by the district coordinator. So each district has been activated, and all those pillars have been activated, and they're working closely. And like it's just like looking at the technical and implementation, and then you look at the high-level partner and coordination and oversight. So this is the structure of the whole response. That is actually, you can see that the structure is well thought of and developed and is in place. But then the challenges are that they are not functioning properly because of lack of resources. And I think that's the major challenge for the difference between the COVID and Ebola. Is during Ebola, there was a lot of resources. And so all those pillars were able to work. And when all those resources came, everybody was able to work and things happened. But like during this COVID, these structures were activated, but there's minimum support to all those pillars. So I'll come to PIH response because of time in Sierra Leone. So how does it begin? It all begins through a call. So on April 17th, the president of the country requested a call to talk to Dr. Paul Farmer, myself, and John, who is like the executive director for PIH. So we on that call, he actually requested that PIH be more involved in the national response outbreak, and especially in terms of contact tracing and the laboratory pillar. So, and also he designed an emergency epidemic preparedness advisory committee and asked Paul Farmer to be on that committee. So these are the two things that they asked partners in health. And then immediately after the call, we thought of Ebola, our experience during Ebola. We were like the leaders in contact tracing. I was like the lead of contact tracing in the country. And like we were able to do a fantastic work using community health workers to work in the districts and bring and contact and do contact tracing. So when they asked us, we thought about Ebola, and we thought about the strategies we had during Ebola, and then we implemented them. So it's COVID-2. So immediately after the call, we went to the ministry, we had the various discussions, and the Manager Operations Center, we developed a strategy and operation plan for the supporting contact tracing. So as I was asked to lead the effort, and we did that, and we trained 3 participants from each district as trainers, and then they went ahead and trained 110 community health workers in each district, because the country had about 15,000 community health workers doing health promotion in the community. So we just took from them and trained 110 contact tracers per district. And we also trained and deployed 16 district coordinators to head, because there are 16 districts in the country. And those coordinators are heading the contact tracers in each district and trying, and I'm like supervising the whole process. So we trained a total of 15,400 contact tracers, design a supervisory system to ensure contact tracers are doing fine. And then we developed zonal surveillance teams. So in each district, we divided it into 4 zones, and then we'll have surveillance officers in each zone to make sure that they capture, they respond to every alert and make sure and alert the contact tracers to train contacts. And so, and I think that's really working. And have contact tracing coordinator per district, taking some of the supervision in Kono. So we took some of our staff that worked doing Ebola, that were working as contact tracers and supervisors. Those are the ones we took and trained them and put them in all the districts. And we developed strategies to ensure that the contact tracers are safe. It's not only labeling, but we make sure that they're having PPEs and all those things that will make them safe. And like this is just an organogram that tells how the flow of contact tracing, if a case is alerted, what do you do? He will communicate with the chiefdom surveillance team that will then. So this flow chart, when you have time, you look at it clear, but it's like a great way just to show how the contact tracing works.
We will need to close soon because we're running out of time, Bailor. So
I think it's just 2 slides that I have, 2 more slides.
Please, okay.
So during Ebola, the one important thing that I sensed, that I've been sensing during Ebola, there was denial at first. Okay, when Ebola came, people were denying there is no Ebola or whatever. And then when people started surviving and they started talking, people then believed that Ebola and they complied with the laws that were due. But like during the COVID outbreak, it is funny and it's very, very interesting to me because like at start, everybody believed COVID, but now they tend to not believe it because like they're saying that, oh, what's special about Sierra Leone? A lot of people are surviving and we don't think it's true. We don't think it's Ebola, it's COVID is in Sierra Leone. We know that it's and so that's something that I want to explore and like interview a lot more people to understand why they think it that way. But it's something that I found weird, like doing Ebola at first, there's denial. But doing Ebola, there's a lot of support from NGOs and international community, but now there's no. And even though doing Ebola, the structures were built and they're utilized now, but they are not completely functional because there's limited resources to run the system. And like, this is just a picture that shows like, we're talking about social distancing, but like, this is just a small street in Freetown where people are full, they're not wearing masks and all those things. It just tells you that now at first people were wearing masks and other things, and now they're fed up of everything and they're just doing what they want. So that's a huge challenge right now in the country. Thank you.
Thank you so much, Dr. Barrie. That was a very fascinating presentation. The experience of Ebola, both in East Africa and in West Africa, helping to prepare somehow for this new pandemic. I really want to thank Dr. Alex Coutinho and Dr. Bailor Barrie for their great presentations, and see you next week in our next COVID series. Thank you so much and goodbye everyone. Thank you, Hannah Park, for a great moderation.